showed in about 200 patients, there's a retrospective study where they analyzed about 200 patients treated with a variety of immunosuppressive therapies. Many of them actually had ATG containing regimens with cyclosporine or ATG and prednisone or Campath. And as you see here, most of the patients were intermediate 1 or low risk and had, of course, cytopenia. And what they found actually that about 50% of the patient had a hematologic response, which is pretty remarkable. Either complete response or partial response, and 30% hematologic improvement. And also 30% of this patient became transfusion independent. So these are patients who start with a profound cytopenia and go to and are treated with immunosuppressive therapy. When they looked at the factors correlating with the response rate, they found actually that the Apporach ATG was actually better than the rabbit ATG. Actually, most of the patients actually had ATG and prednisone. And the most relevant factor was actually to have a bone marrow blast percentage less than 5%. There was no correlation with HLA-DR15 in the response rate. Interesting also is that although the follow-up is not too long, but those actually who had a hematologic response had a significant longer survival than the others, which is intuitive, but I think it's important to observe it. New drugs that are coming up, still in clinical trials, are interesting is those targeting TGFbeta. MDS patients often have an increased SMAD2 or 3 signaling in the bone marrow, which leads to an effective erythropoiesis. So by blocking the TGFbeta effect, these drugs are meant to correct this ineffective erythropoiesis and allow the cells to mature more into red cell lineage, so to correct anemia. And there's been a recent phase 2 studies, and with there are 2 drugs, sotatercept and sotatercept. And I think we look forward to having more definitive data on that. High-risk patients, of course, the standard treatment is azacitidine and decitabine. The interesting thing is, I showed, if I combine, just thinking of the relevance of the mutation that I showed before, the prognosis changes based on the mutation the patient have. There are very bad prognostic factors like AXL1 or TET2, and this study actually analyzed the response rate across this mutation of azacitidine, of 5-azacitidine. And I think it's interesting that the response was similar across all the mutations. So patient with TET2, for example, with positive or negative for TET2, or RUNX1 or XL1, had similar outcome, had a similar survival with treatment with azacitidine. The one actually that did not have the same results was the patient with P53 mutation, or patient with a secondary MDS, with AML, sorry, compared to MDS, or secondary AML versus primary AML. But you see that cytogenetic risk was not a factor, was not significantly different, the response to azacitidine or the addition to it. However, the response to these are the IPS score still separates the survival curves of patients responding to azacitidine. Because I'm a transplant doctor, I want to remind everybody that transplant is the way to save a lot of these patients, especially when they fail hypomethylated agents. There's still like about 40 to 50% probability to cure these patients with an allo transplant. And I don't have the time, but there's now plenty of data with also haploidentical transplants. But what I actually, before I go there, the SWOG actually published a paper last year if you were thinking of combining azacitidine with other drugs, it failed. The study failed to show a benefit of azacitidine with lenalidomide or vorinostat in MDS patients. The only benefit actually was shown in CMML patient, where the combination of azacitidine and lenalidomide was superior to azacitidine alone. There are many drugs under investigation, many clinical trials. The pathways similar to what was presented like before me on lysosome and the DNMT3A and the checkpoint inhibitors. I think some of these drugs have been just described, the DHT inhibitors. There's a response, initial study showing the response rate, about 50% response rate in MDS patients. And there's new drugs like rigosertib, which is actually a PI3K inhibitor that may actually seem to be some benefit in patients with monosomy 7 or trisomy, and who actually have a primary failing primary treatment with activating agents. A recent actually algorithm, just to summarize the MDS part, is actually patient with low risk MDS. If they have only anemia and deletion 5, of course they go to lenalidomide, erythropoietin, or other drugs, or low dose actually hypomethylated agents are indicated. If they have high-risk disease, transplant is the first option, still the best option for those who are candidates for transplant. Or for non-transplant candidate, actually, hypomethylated agents remain the best treatment. Just want to remind you that actually the old patients or older patients can still benefit from transplant. We have now a large variety of reduced intensity of non-myeloablative conditioning regimen that allows us to transplant patient up to 70, 75 years of age. I think that the interesting study I like to present all the time is actually this one here. It's an old study, but I think it's still very valid. To have a consult or not to have a consult about transplant for MDS patients actually has a survival significance. So patients actually, what I think this slide, this study shows is actually that those of you who are against transplant to begin with may miss the opportunity on some patients. And not necessarily every patient consulted for transplant will receive a transplant, as you show here in this slide. Switching quickly to MPNs, we know that MPNs are now characterized pretty well, in the majority of them, by molecular findings with JAK2 mutation or pyruvate mutation or MPL mutation, and then a small group of those patients actually have no mutation or other minor mutations. And we'll talk about this thing. So the prognosis score, again, is also based on the classic dynamic IPS plus. We value these factors: the age, hemoglobin, white cell count, number of blasts in the blood, the presence of symptoms, but also we now value the role of platelet numbers, unfavorable cytogenetics, and transfusion requirements. These actually characterize patients with a survival of less than 2 years to up to 10 years based on these factors. More recently, actually, Alessandro Vanucchi in Italy actually has proposed and validated a score based only on genetic mutation, on the genetic profile, and added a revised version of the DIPS or score with a mutation component, identifying actually the patients who are triple negative, who don't have any either JAK2 or MPL or pyruvate mutation, have the worst prognosis, and that's per se a very significant risk factors for these patients. So the treatment for myelofibrosis in particular remains still very different based on the patient characteristics. We can treat anemia, we can treat the splenomegaly, we can improve the symptoms. Transplant remains the only curative therapy so far, as I'll show you in a second. But I think there are a few new data on managing the cytopenias, especially in older patients. We can actually add ruxolitinib, the JAK2 inhibitor, to danazol. There is some data with INITs, lenalidomide, and there are new actually the TGFbeta inhibitor that I mentioned before, which has been also tested in a few patients with myelofibrosis. JAK2 inhibition, the ruxolitinib remains the standard. This is the only drug approved, the only JAK2 inhibitor approved in myelofibrosis. It not only improves the symptoms, decrease in the splenomegaly. There's also some data indicating actually may survive, may allow a longer survival or reduce the mortality of these patients with most invasive symptoms. A few more recent data have shown actually that there are some potentially new drugs like the telomerase inhibitor, like imelstat, targets telomerase. It was shown by the Mayo Clinic that there is in a small number of patients, a small group of patients with JAK2 positive and myelofibrosis, there was actually a reverse of the fibrosis in the bone marrow. This has not been seen before, other than with bone marrow transplant, which is very exciting. But I think there's not enough data yet to validate this initial study. There are a combination of ruxolitinib and decitabine. There's a study of the MPN Research Consortium where they tested in a phase 1 study in patients transforming with myelofibrosis transforming into ML. The efficacy, actually, there was some benefits in using decitabine and JAK2 inhibitor together. Interferon has been a big topic of debate. Pegylated interferon has been shown to be very effective in polycythemia vera and essential thrombocythemia as a drug in patients especially resistant or relapsing after hydroxyurea. Is also probably the only drug able to induce a molecular remission in these patients. So and the pegylated version of